Well, thank you everyone for joining today's webcast, AI and Medical Records, a New Era in Healthcare. I am Ashley Howell. I'm pleased to be today's moderator. Um, Today we are going to begin with some introductions, and then we're going to actually have a live demo. So it's going to be a great conversation here today. So I thank you all for joining us. Today's webinar will be recorded, so we'll be sharing out the recording. Um, you can look for that tomorrow in your inbox. So with that, I'm going to pass things over to Michael to introduce us to our speakers today.
All right. Well, thank you, everybody. I'm Mike Magalsky with InfoVia, and I'm just happy to be a little part of this revolution that's coming about in our industry, where we can grab a hold of textual data through AI and this tool called DataVox that Bill will be demoing today, and help our population with managing their health, specifically from the first moment they set foot in the ER room or the doctor's office. And so I'm happy today to have two friends of mine on with us. One is Bill Inmon. We've become friends in recent years, and I'm honored to have him on my list of friends. Bill is the father of the data warehouse, and in lots of circles considered one of the most influential computer scientists to have walked the face of the earth. Bill's contributed to our industry, and I owe my career in large part to the to what Bill has done to bring his best practices for the term he coined, data warehouse, to the world. And so, thank you, Bill. Appreciate you joining today. Also, Dr. David Hightower is also a personal friend of mine. He's helped our family with medical situations, but has practiced medicine for 31 years, mostly here in Boise, Idaho, and has been an ER doc that most of that time, a little bit of wound care as well. And David brings this wealth of experience around the clinical side of how data can help uh, with our with our emergency medicine specifically. So today we're going to talk a little bit about the challenges with medical records. So David and I were speaking a few weeks ago about just how stressful it is to have someone's life and livelihood in your hands, and so many of his peers are being challenged in that regard, both from a real desire to be in the business of saving lives, making people more comfortable, helping people manage their health, but also at the same time being liable for the outcome of that. And Bill and I were talking around the same time about how much value there is buried in text, and specifically doctor's notes in medical records. And so we decided to pull together here and talk about this a little bit. So, David, Dr. Hightower, can you talk a little bit to me about how you're how you are affected by this pressure as someone maybe with heart complications walks into the ER room? What does that mean for you? What are the thought processes that go through your head, and then talk a little bit about the risks therein.
Well, I think the for each of you have probably gone to the emergency department and or had a family member go that's gone to the emergency department. And, for myself, it's all about my patient. And so I want to provide the best patient care that I possibly can. And at times, sometimes you have to make decisions very quickly. And, with the vast amount of data as far as medical charts, et cetera, sometimes it can be somewhat daunting. And certainly you get the big picture as far as usually on a person's past medical history, but there's things that can be buried in the chart and the history, present illness, and other areas that then can really make a huge difference, particularly in my setting, to provide that care from a physical standpoint, but then also from a what's most important to the patient standpoint. Also,
Mm-hmm.
and those things, if they're buried in the chart, then you just don't have that opportunity to provide the best care for the patient, and it can make a difference in that acute setting. And it's also stressful in general for myself as well as my peers. We're held at a high standard, and that high standard is that if it's available in the record, then you're responsible for being have reviewed that medical record, and the stuff that's really salient. You're responsible for that, and so that can also add to the stress. And medical records aren't getting any smaller. If anything, that's vice versa, particularly those individuals with chronic diseases.
Sure. So I think what you said there is that whether the medical record is 4 or 40 pages, you have to make a split-second decision, and you're responsible for what's in that medical record, regardless of whether you actually have time as a human to read that record in its thorough manner.
In some ways, yes, you are.
That almost seems like an impossible assignment, a mission impossible, so to speak.
It can be
So
frustrating.
how do you and your colleagues handle that today?
You do the best you can with this situation, and sometimes you have to make decisions without all the data, and that's where it can be frustrating for the patient, frustrating for the doctor, because ultimately we really want to make the best decisions for them and what's important to the patient.
You've mentioned to me some about the stresses and the effects of those stresses that it's had on you and your colleagues, even some of them going so far as to retire early from the trade. We're at a point where supply and demand is at an imbalance in our healthcare system. We don't have enough doctors, and yet the stress and or liability is causing people to retire. What can we do about that?
Things like this would be helpful. The average for a male who's in emergency medicine, the average length of practice is 17 years nationally right now. For a female, it's 12 years. I'm somewhat unusual because I've done it for 31 years, but that extra stress is, that's, the amount of data and having to deal with the medical record and find what you need to provide the care that you think that the patient needs. It just adds to the frustrations of on a day-to-day basis if you can't access it or if it's difficult to find. And quite frankly, somewhat the sheer amount is also a challenge. And any of those things that would be helpful to make it easier and more available, more organized, would be helpful to make my day-to-day life much easier, so I could spend more time with the patient, not more time just sorting through this amount of data. And the patients are frustrated too, because they see you as impersonal, et cetera, when you're trying to search through the medical record, et cetera. So any little help like this, I think would across the board would be widely accepted, and it would help improve patient care and ultimately improve the patient experience. And I think that's probably one of the biggest things, to improve that patient experience for the patient and their family.
Yeah, I appreciate that you've turned the focus back to the patient. I think that's probably a testament to your longevity in the industry. I have no doubt that you and your colleagues want to help the people, want to help the patients to recover, want to help them to find the best treatment, be the most comfortable, live the longest. And at the same time, I did the quick math there, and you're in school for 20 to 24 years, so that on average people practice 12 to 17. It seems like we might be able to, with using technology, to relieve some of that stress and liability on the practitioner, on the
Mhm.
doctor themselves. Maybe we could extend that 12 to 17 years to something more like your 31 that you've contributed.
Mhm. Yeah, I would
So
hope. I think that could make a huge difference on job satisfaction. Because for those of us that are in the field, it's all about our patient and their experience, and if they're frustrated, et cetera, and the technology is pulling us away from the patient instead of helping us, more face to face and managing their health care. That's really that's what's it all about for docs. That's why we went into it, not to be spending our time with electronic medical record, but to be spending the time with where it matters, which is with the patient on face to face, and but yet still know the salient issues.
Sure. Well, I'm gonna turn it over to Bill for a little demo here in a second, but first I'm going to bring in the healthcare network, the system into the equation. We don't have anybody represented here that's a healthcare administrator, but I was having lunch the other day with the CIO of an urgent care provider, and they're under immense pressure to move more people through the ER. First and foremost, to keep people in the waiting room less time. And second of all, they have more throughput from a profitability perspective. So we have to be able to make the dollars work in the healthcare system as well. And that throughput and waiting time, not to mention the limitation of the providers themselves and access to quality providers such as yourself, those are all factors that are putting a lot of pressure on the healthcare system. In fact, this gentleman mentioned that there's even as Medicaid is getting reviewed and challenged in some cases, then the hospital systems receive less pay for their services. Medicaid is just one example. Other payers want to keep the cost of health care low, and all of that's working together to reduce the amount of revenue per patient for a health system as well. So if we can speed up the visit time of a patient in an urgent care facility or ER, then the patient wins, less time waiting, sometimes in pain. The healthcare system wins, more profitability, better utilization, and the provider wins because you're more informed and you have better. At the end of the day, you feel like you've helped more people in a more significant way, done your best work. If the technology can help you move more people through the system. If the technology isn't helping, then we're just putting more stress on our providers, aren't we? But
Correct.
by shooting more people through the system. So we really have to use that technology. Well, Bill, you've been quiet. I want to turn it over to you to talk a little bit about your DataVox technology and show us how you can process a medical record in a short amount of time and produce value that Dr. Hightower and his peers could use in an urgent care situation.
Thank you, Mike. First off, can you enable me to share my screen? Let me,
Absolutely.
I need.
Should be able to hit the share screen button now, Bill.
Okay.
So
Hello.
Bill's been working for 20 years or so on text processing algorithms and has it down to a science. He's going to show us here his solution called DataVox and the ability to process a medical record and produce the critical elements of that for a doctor to make a more informed and well-rounded decision, even especially in cases where urgent care and time is of the essence.
Okay. Thank you, Mike, and thank you, Dr. Hightower. I want to begin by saying, number one, categorically, I'm not a doctor. If you're waiting for great medical proclamations from Bill Inmon, you're going to be very disappointed. However, I am a technician, and number one. Number two, I myself have been in the emergency room on numerous occasions, and anything I can do to help medicine and doctors, as far as I'm concerned, is a good thing to do. So what we're going to show you here today is how we can alleviate doctors from having to do what I would call triage on the medical record. There's the computer can read the text of a medical record and process it far faster than any human being on this earth. So that's what I'm going to demonstrate for you today. I want to begin with a little conversation about a medical record. Now, let me tell you a little bit about this medical record before we go any further. This is a real medical record. However, it is not subject to the laws of HIPAA. This medical record came from Brazil, and Brazil isn't subject to the laws of HIPAA, number one. Number two, this record has been de-identified and translated from Portuguese into English. And number three, this record was gathered before HIPAA was even a law. So we have something kind of a rarity here. We have an actual medical record that can be disclosed and shown in public. Now, while I'm on HIPAA, in terms of what I'm about to show you, the technology can run on the cloud or it can run on premise. So if you're worried about the need to keep all of your information within the doors of your corporation, no problem. What I'm showing you here today can be as easily run inside your corporation as it can on the cloud. So with that, this is the medical record from a hospital. This is the journey of a patient through the hospital. Again, the names have been de-identified. We gave this lady the name of Maria, and this is some information about her. But then we start to talk about what has happened to her in the hospital. And again, I'm not a doctor. I don't even know what most of these terms mean. But a medical professional will know what these terms will mean. Note that this is in the form of text. There's no structure, no formal structure, but I don't think even much of any structure at all in this information. And this, the lack of structure and text is typical of the medical record. Now, this medical record is only about 3 or 4 pages in length, and there are other medical records that are far bigger than this one. And so if you were Maria and you were entering the hospital and you needed to have treatment in the emergency room, a doctor would have to read this record. How long would it take? Well, it depends on the complexity of the record, the contents, and what the doctor's looking for. But I don't think it's an exaggeration to say that maybe 10 minutes, maybe 15 minutes, in the case of a big record, even longer than that. So that's the kind of time frame that we're looking at. If we're sitting here as Maria and we're looking for help from the emergency room, this is what we are facing. So this is what the input looks like. Now I'm actually going to process this record for you to show you two things: how simple and how fast it is. So I want to take you over to my handy little program here. And here we have a simple screen. We liken the screen to an ATM screen. If you can use an ATM machine, you can use the this particular technology. So what do you have to tell us in order to analyze Maria's record? Well, first off, you have to give us a name so that we'll recognize the output, because we may have a lot of these records going through and we don't want to lose your record. So I'm going to call this record Maria 001. So that you have to give me that. The second thing you have to give me is what you want to do with the record. And this one is going to be emergency room triage for Dr. Hightower in the month of March. And you have your choice of a number of these indications of what you're looking for. Today we've chosen that one. And how long does that take? It takes seconds. Another thing is you have to tell us the language you want to operate in. Right now, most everybody operates in English, but we can operate in other languages. Then you have to tell me the record that you want. And we go and select the record that we want off over here. So let me quickly review what you have to tell me. You got to tell me a name to identify things. You got to tell me what you want to do. You have to tell me what record you want to start to process. And then you start to process the record. And here we see Maria 1 processing, and it's loaded the file. And guess what? It is finished. It took us internal to the computer about 1 second to process the file. And compare that to a doctor that's got to spend anywhere from 5 minutes to 20 minutes looking for the information. So simplicity of use. You don't have to be a technician to use this, and speed of use. This is brutally fast. And then you say, okay, Bill, thanks for telling me that. What did my output look like? So let's go take a look at what your output looked like. And let me pull it up here. And the output that you look, whoops, gotta do this. The output we're going to look at, this is the record itself. Now, what have we done? This is a triage investigation. So number one, this is the record for Maria. Number one. Number two, we've looked through the record looking for all of the conditions that might be important to an emergency room doctor in terms of assessing the difficulty and the challenge with the patient. And then number three, perhaps even more importantly, in addition to finding ventilation, we find the words that precede and follow ventilation. What this gives the doctor the chance to do is to look at the context of the word. And so you have within 1 second's time the important things you're looking for and its context. So at this point in time, we've alleviated the doctor from a lot of work that's unnecessary. And now, if the doctor reads this and sees something that says, "Oh my gosh, this is something I need to look into," then the doctor can look more directly into the record. So this is the facility for enhancing the life of the patient and the work that the doctor has to do. And so now, without going into technology, there are other things in this record. I've purposely removed them, but from a technical standpoint, there are other pieces of information that might be useful, but especially to the technician, but to the doctor, this is the information that gets, it doesn't do it exactly immediately. It does take a few seconds to do it, but for all practical purposes, this is done immediately. So I'm going to turn it back over to Mike and Dr. Hightower now. That's technology at work to enhance medicine.
Keep that on the screen if you would, Bill.
Okay.
Dr. Hightower, if a person with this record walked through your doors at the ER and complained of chest pains, would you consider that a dire situation?
Yes.
About how long would your internal clock start clicking that you need to react and make a decision on?
It'd be immediate. And in this case, and if you change it to a person that came in with shortness of breath, it would, both of those things would be something immediate that, how am I going to be addressing that, particularly how, their vitals and how severe they are.
So even assuming that they walked in and handed you the healthcare record printed form, if you had it immediately available to you, about how long you've looked at this health record? You told me it took you about 20 minutes to look over it and really process it and get the valid information. Would you say that's average time to do a good job of processing a medical record as a human reading through that?
Certainly it depends upon how in-depth you want to look at, and probably 20 minutes, maybe a little bit longer, but even 10 in those early, that's the first 10 minutes that can make a huge difference, such as this patient here, why I pointed this one out. One of the things that was buried in this chart is the fact that this person had she was 78 years old, but they had difficulty getting her off a ventilator. And so if she was eventually did get off the ventilator and then comes back into the emergency department with chest pain or shortness of breath, particularly if she was short of breath. And I was debating whether I'm going to have to put her back on the ventilator. Even if she is full code, just that fact of difficulty getting off the ventilator, that's going to prompt, if I find that's going to prompt me at least to have a very quick discussion with her but also her family already. And I may react differently by not putting her on the ventilator when I see that, just because of, they had such a difficult time getting her on or off, excuse me, family, and it's miserable for family and patients. So in this case, it would make a difference. And I would probably be more, I'd try to do everything possible and even may be a little more hesitant to put them on than I would a person that doesn't have that in their background. So it can make a huge difference there. And this was buried within the chart itself.
So let me get that right. You said even if they were full code, meaning heart and breathing stopped, right?
No, I mean that if the patient requested that everything to be done possible, I would, that we would put him on. We would do everything possible, but we at least have a quick discussion. Are you sure that you want to be back on the vent and life support at this point in time after you had such a long course and they had such a difficulty getting you off
I see.
of that ventilator? Or is it something that, we want to give everything possible, even though it may take a little more risk, and we will try to go a little bit slower and give you a little time, knowing that that's a risk, but, then not put, at least give you a chance to not have to be placed back on that ventilator. So,
Okay.
And a 78-year-old that has trouble getting off the vent, the likelihood, if they've had trouble before, likely is high that they're going to have trouble again. And no one would want to be on that long term, as well as
Okay,
family
so
members. So
I think I can understand a little the layman's terms, but what you're saying is full code, meaning they're willing to accept any treatment you're willing to recommend.
Mhm.
And the default would be to put this person immediately on a ventilator.
Mhm.
But when you notice that these particular records, when these come to your attention, it changes your default treatment to something different, because at the minimum, she might never come off of it. At the maximum, she's going to be very uncomfortable.
Correct.
Did I understand that right?
Correct. Correct. And um, and so in this case, they would, it would be something that needs to have a conversation before I just jump, and place them on and force them into being on a ventilator. So,
Okay.
it's a fine line. You still want to do what the patient wants long term, but bringing that to their attention, more than likely, I would expect they would say, yeah, you may have to put me on it, but can we do everything, even though I know that may be risky, and I even may make things worse by waiting, but I would really like to give everything possible so that we don't have to go and place a person on a vent. So, and that's the guy in this case.
So the value here is clearly potentially life and death, but at least discomfort of the patient.
Right. It's patient
And
satisfaction. What do they want? What would they want long term? What would they want? And it's all about what they and the patient and the family would want. So
the result of this was the output of a process that took seconds gave you information that you would need to have a discussion, probably a short and urgent discussion with the family to decide whether to proceed with the ventilator or not.
correct. We'd be simultaneously having that discussion while my staff would be preparing to intubate them and place them on the life support ventilator. We'd have the conversation virtually simultaneously.
So the value is almost infinite. Now the question is, what's the cost? Because health systems are more and more cost conscious, and they need to move people through the ER. They need to minimize the time they spend in the waiting rooms. Bill, you showed us this. You had 3 or 4 prompts that you had to produce there. probably that could be automated into a medical system to provide those prompts. Maybe that could even be done before, by the triage nurse before the doctor even walks into the room. But the processing of this record was quite surprising to me. 1 second. What do you typically see in the range of processing medical records? Because they range drastically in terms of their length. What's the
Uh,
cost in terms of elapsed time to do this processing?
Mike, that's an interesting question, and I'll give you a technical answer. The answer is we can make it happen as fast as you want. The record that we processed on today was done on one machine, and at the rate of processing on one machine, we've measured it. We can process a record in a third of a second. That's the actual processing time. However,
Okay.
if you get a really large medical record, if you really want to process it quickly, you can process it on multiple machines. So now it's expensive to do that because it costs you hardware. But if you had 1,000-page medical record and you wanted to process it in 2 seconds time, you could, but the cost would be multiple machines. So most people, and that's kind of far-fetched. I don't know. Maybe you really would want to do that someday. But in terms of a medical record that is anywhere from 10 to 20 pages on one machine, that can be processed easily in 2 seconds time.
Mhm.
Well, that's practically instantaneously, I think, for all practical purposes.
Yeah.
So, what also is interesting then there, if the cost in terms of elapsed time is negligible, then the cost in terms of dollars to process this would be the main factor. Let's take, since it's hard to really guess at what the hardware costs of an on-prem instance of this would be, several $1,000s just to get it set up. We know it would be that. Let's just look at the cloud costs. You shared with me earlier last week about the cost of processing these records from from the cost to the institution, to the medical system. What generally would that cost run in terms of dollars and cents?
For what you would consider to be a normal size medical record. And for our purposes, let's call that a 20-page record. We typically would charge something like $1. Now, depending on how you wanted to do it. Now, like I said, you can get fancy and you want to process something immediately over multiple machines, then the cost does go up. But that's very unlikely to ever happen. So a good ballpark figure is for $1 to process a record.
Well, even if it was $10, if I'm walking into the ER and the doctor can see me faster, make a better decision, and it costs me $10, that seems like a pretty good investment from a patient perspective. I'm speaking from the patient perspective. I'm willing to pay even $10 for that, additional service. I think we also have the healthcare system who wants to move people through faster. This helps the doctor make faster, better decisions. We have the doctor who wants to provide better healthcare to the patient. So really everybody is in line with a solution like this that would improve the processing of that patient record and the decision making of the healthcare professional to improve the health and treatment of the patient. I can't see any downsides. Can you, Dr. Hightower?
No, actually, I see some advantages. $10 to make my life easier. I'd pay the $10 myself if that was an option. Quite frankly, the thing that's advantage here is you can tailor it for things that are typically not easily accessible in the summary of the medical record, such as quality of life discussions. Those things are documented, but they're usually documented and in paragraph form, etc. And that would be something that could be potentially helpful if I glanced at that and that discussion was had, and within that the patient said, of all the things I absolutely not, unless absolutely necessary, I don't want to be put on a ventilator. Just that one statement. And those things are typically buried because, they have people assume that it's in the advanced directives, but sometimes it gives you more clarity by, being able to pull that up. The second is how much does it cost for me to put a person on a ventilator? I'm sure it's more than $10. And so other things that people don't think about is, the population health stuff, as far as, you could search the chart to see things that would help them be referred to palliative care and other specialties if necessary to increase the patient's health care and satisfaction, as well as what's called social determinants, which makes a huge difference because, if the patient has risk factors for certain things, such as can't afford their prescription or have problems with their living situation, it doesn't matter if I'm writing a prescription, they can't afford it. It doesn't matter if I refer them to someplace and they have no transportation. All those things take time. And the advantage of this is that I could potentially put in the things that I'd be looking for, and that could prompt me that this person's at a risk for such and such. Therefore, I could address the patient as a whole, and there would be more compliance. And so all those things, this has the potential of addressing.
So you or the health system could even look deeper into how to treat that patient if it was even something as simple as they need a ride arranged so they can get to their next referral
Right.
appointment.
Yes. Because right now, virtually there's been a mandate that we address what's called social determinants, and there's a number of them, and and it makes sense because so much some of these social things makes a difference on compliance as well as the patient's overall care. And but sometimes it's hard to get a clear idea. Either patients they won't they're embarrassed about it. They won't tell you directly. There's a number of reasons, but if I could set it up where I had particular something screens that would potentially highlight some of these things I'm talking about, it could potentially then help me address the patient overall, instead of just assuming that it's okay. But then also getting social service involved when necessary, or don't want to consult them if it's not necessary, if the system could do it by itself.
Well, let's talk about that a little bit, Bill. The idea of integrating this into the hospital system or the emergency room system, the urgent care system. You've showed us how you can, in a few seconds, select a few options. It would seem that there could be an interface where this could be launched from the health system, and then the results, column D in your outline here, maybe column B through D, would all be available to the doc who's making the decision. That's kind of on the way into the ER, or when the doctor enters the room. When the doctor leaves the room, they're prescribing some follow-up tests or medications or referrals, and it would seem that you could process the record with sort of a different angle, a different vantage point, and maybe pull out those social determinants from that. How would you go about doing that?
Well, to tell you the truth, Mike, one of the real strengths of the DataVox technology is the fact of being able, first off, to find anything that's there. It may hide from a human being, but it doesn't hide from the computer. Number one, and number two, to look at and find very gray area things. We do a lot outside of the medical system. And when you're looking at things like customer sentiment, when you're looking through contracts, man, customer sentiment, people talk a million ways. And you've got to be able to sort through those shades of gray that people have. So I have great confidence in the ability to be able to find the social determinants. Now, we're going to have to add a little bit to the knowledge we have in the system, but that's what we're made for. So can it be done? Now, a second issue that you brought up is what happens if you do this in-house, on premise. And I personally can imagine, having talked to a number of healthcare organizations, that nearly everybody, because of HIPAA, is going to want to do this in-house. We will install the system in-house for you, show you the equipment that you need and how to install it. And we will even go so far as to show you how it can be integrated with the other systems that you have. The output is simple. We have a simple database, and here you see one of them. We have a simple database that's output. The database is compatible with every database technology that we know of, SQL Server, Oracle, DB2, Teradata, MySQL, all of those, first off, is compatible with. So it just appears as another file to your system. So integrating the output from what we have here is a no-brainer. However, we will be happy to help you, show you how to do that on the day that you bring it in into your own organization.
Thanks, Bill. It just seems to me like if I'm willing as the patient to pay up to 10x what it costs you to process this record, because it's worth it to me, the patient, Dr. Hightower is willing to pay that because it helps him do a better job. I got to think that the payers and probably the malpractice insurance companies out there are going to see this as a risk mitigation and cost mitigation opportunity. So they might be willing to come to the board, and the health systems themselves want to see better health care with lower costs and faster throughput. So I just don't see a downside to it.
And one of the other things is the technology that we have here today is, we're not building it. It's already built. It's industrial strength. It can be parallelized. I might add, it can run in multiple languages. We can, right now, we are equipped to do English, Spanish, Portuguese, Italian, and Arabic. But it takes us about a week to add a new language, should you want it in a different language. So we're, again, I want to talk about my motivation. Certainly as a technician, this has been a wonderful experience for me. But the truth of the matter is, I've had some health issues in my life, and I want to do what I can to do my part to advance and help medicine and doctors.
Well, I think you've done a little more than your part, Bill, in your 60 years and 60 some books written. In fact, I would like to, first of all, congratulate you on all of those books and papers. I did the quick math, just estimating, and you may have contributed between 6 and 9 million words to our industry in publications that you've written. Tell us a little bit about your books, and then go ahead and make your big announcement. And then we'll go to Q&A, because we have some questions and answers coming in from the audience. Anybody else who has a question, feel free to submit that in the chat there in the Q&A, and we'll cover those at the end here. Back to you, Bill.
When I look over my life and see the books that I've written, it's true I've written that number of books. But when I was in college, I avoided courses where you had to do writing. So how this happened is a mystery to me. Yes, I've written a number of books. The most new book coming out 3 weeks from today, I just looked at the cover a few minutes ago, that we're working with the publisher, is one I'm excited about. The name of the book is Artificial Intelligence in Medical Records, Modernizing Medical Research. And it's really for a little bit different subject. Today, we talked about the usage of our technology in the clinical sense, and I'm very happy for that. But another important use of our technology, being able to read and codify medical records, is in terms of research. We did a project a while back just to see if we could do it. We took COVID. We took medical records for COVID. We took about, 20,000 medical records that had COVID in it. And we were able to quickly come up with such things as, how does COVID relate to smoking? How does COVID relate to taking aspirin? How does COVID relate to gender? Do men have more cases of it than women do, et cetera, and so forth? In terms of medical research, I think there is as much value in medical research as there is on the clinical side. Having stated that, I'm deliriously happy that we can make a contribution on the clinical side. If you're interested in the book is coming out the first week of April, and it's the publisher of the book is Technics Publications. And I believe, I'm not sure about this, I think you can even order it on Amazon right now.
Okay.
But for sure, if you go see Technics Publication, that's where the book will be coming out from.
Yeah, if you could stop sharing, Bill, we have a slide about that. And Bill and I were just meeting with his publisher last week. We happened to all be at the same conference down in Phoenix last week, and so we received the rights, the honor, I guess you would say, of being able to present or announce this today on this show. So Infovia is honored to be hosting Bill Inmon, and then honored to introduce his newest book as shown here by Technics Publications. Bill, how many books is this for you published in print?
Mike, I'm almost embarrassed. It's my 72nd book.
Oh, wow. I think my math was wrong. I think I only considered something like 60 when I did the.
It's pretty good for someone who doesn't like to write.
Well, I sure am honored to have both of you here today. We do have some questions for the group. My friend Jason down from Atlanta asked about maybe a graph database, and specifically the use case of presenting some similar cases to the physician to help them make a decision. Thought about that application?
We have direct support of graph databases. We support Neo4j, we support Ultipa, we support TigerGraph, and you can go, and we even have a demonstration of it. You can go directly from the output that we produce into a graph database.
Okay.
And if you're interested, contact me and I can send you the demonstration that we have that does that.
Okay. So for those who are not that technical on the call, graph database would be it's a database type, a special type of database that measures or stores the strength of relationships between objects. And so a relationship between the medical record of Maria walking into the ER compared to other people like her in her demographic, in her age range, with her symptoms and similar medical record, the treatments and the results of those records, the results of those treatments could be very useful. Dr. Hightower, do you have anything like that today?
It's a little out of my area of expertise because that's more in the population health side, so I'm not familiar about that, at least in my area of expertise, because I'm more on the clinical side. So to be able to answer that.
Yeah. But from your perspective, if you had at your fingertips a way to analyze this person's situation compared to all those past, even in your career, your brain holds, well, I'll tell you what my brain does. My brain can remember pretty good what I did yesterday and something about what I did last week, but you've been practicing 31 years. It's probably not humanly possible to have all the information about all the cases you've seen, what the treatments were and what the effect of those.
No, the thing that would have been really nice, though, if we would have had this is during COVID, because then it would be real time as far as things, how do you address this person at this age group, et cetera. And, I went through all of COVID, and it would have been really helpful during the pandemic, because we really just didn't know, which individuals would be what to do with a particular age group or individuals as with a pandemic there during parts of it. And so I could see that could be very much of a value if you could correlate, how similar individuals in the past have reacted to this patient that's now sitting right in front of me. And we really just did not have that. We were sort of trying things blindly, and so I could see that could be very helpful.
There were no experts. You were literally practicing at that point, right?
Correct.
Yes. That's a good point. I hadn't thought about that. So that's a good question, Jason. Are there any others that have come in? Ashley? Anyone else have Q&A for Dr. Hightower or Mr. Bill Inmon?
No other questions came in.
Okay. Well, then we will wrap it up. I'll give each of you a moment to just take a last pass at closing arguments, so to speak. And for those who joined us today, we appreciate that. For those watching a replay at a later time, we thank you for that. You can contact us here at Infovia if you want to get a hold of either one of these individuals, or if you'd like our help in creating more value from your data, whether it be in the medical space, in the education space, in the manufacturing space, in the finance space, the insurance space. We have experience in those areas, and we would love to help you make better use out of your data, like has been demonstrated today. So with that, I'll turn it back to you, Bill, for your closing comments, and then Dr. Hightower, and then back to Ashley.
Well, thank you. First off, it's been an honor talking with everybody. I hope that what you've seen you find to be interesting, and I hope that we can make a difference in helping hospitals, doctors, and patients. Thank you.
Thank you, Bill.
From my standpoint, I just hope that those that are listening are involved. It's all about the patient care acutely, but then also overall health care for the population in general. And any of these things, the choice is going to be either to try to use it to be helpful and then potentially improve a physician's practice as well as the overall patient's health care. Versus the explosion of data is just going to inundate and in the long run potentially pull the physician away from the patient. So hopefully it can be used as a benefit. So
excellent. Well, thank you again. Back to you, Ashley.
Well, thank you to today's speakers. It's a very valuable conversation. Hope the attendees enjoyed it. We will be sending out the recording and encourage you to share it with anyone that might benefit. Thank you again for taking time out of your day to spend with us. Have a great rest of your day.